2021. And today our first presentation is Free Trade, Food Prices and Obesity in Mexico by Tara Templin. Tara, you can roll up your screen now. Tara is a health policy PhD student specializing in health economics at Stanford University. Her research interests focus on health system evaluation and the causes of population health improvement. Before Stanford, she worked at the University of Washington's Institute for Health Metrics and Evaluation, studying the allocation of financial resources for health. Tara, it's all yours.
Great. 1 second. We're having some issues.
Take your time.
Screen. Application. Does this work?
It came up?
Yep.
Great.
Good. All right, fantastic. Can everyone see full screen? Yes?
Yes.
Yes, wonderful. All right, well, thank you very much for inviting me to speak here today. I'm thrilled to be sharing this work with you. So it's well known that obesity is rising globally. Over the past 30 years, obesity prevalence, meaning people with a BMI above 30, has doubled, as you can see on the chart. If we expand to consider adults with a BMI above 25, prevalence of overweight and obesity has increased from 22% to 40%. And importantly, this is not just a rich country problem. In fact, around 2/3 of the world's overweight and obese individuals are living in low or middle income countries. And in Mexico, this issue has been particularly acute. Mexico is the second most obese country in the world, only after the United States, but the rise has been much faster, averaging 2 percentage points per year. The consequences of obesity are well known, namely that obesity has been linked to cardiovascular disease, diabetes, and cancers. And these consequences are unambiguously bad for public health. But much less is known about the causes of obesity. There's debate about the relative importance of food prices, time to prepare nutritious calories, physical activity, education, addictive behaviors, and genetic predispositions. So today we're going to focus on the price aspect. Namely, we'll look at the role that declining food prices play in rising obesity. And in the graph below, you can see the World Food Price Index over time. And for most major food groups, prices have been declining. Declining real food prices should enable people to purchase the same number of calories for a cheaper price. However, there's also evidence that cheaper calories tend to be found in high sodium and high sugar foods that are easy to preserve. And there's an important tension here for household well-being or household welfare when food prices decline. Welfare could increase if cheaper food enables households to meet basic needs and perhaps even reduce undernutrition. But welfare could decrease with obesity due to increased healthcare costs caused by the diseases caused by these cheaper calories, namely obesity, diabetes, and cardiovascular disease. So from an economic perspective, if the declining real food prices from free trade cause obesity, there are ambiguous effects of free trade on consumer welfare. In our paper, we zoom into Mexico as a research setting. As I mentioned, Mexico has one of the most rapid obesity rises in the world. It also saw a rapid economic liberalization with declining consumer prices due to the North American Free Trade Agreement. In this paper, we document that NAFTA decreased food prices, and in response, households bought more calories, particularly sugar. And we also document that obesity and type 2 diabetes increased in response to declining food prices. To perform this analysis, we aggregate new data sources to investigate our research question. Specifically, we identify data sources for each link in the causal chain from NAFTA tariff reductions to obesity. So starting with tariff rates on food products, linking to product level consumer prices, and finally linking to product consumption and health outcomes in household health surveys. So let's first look at tariffs. We use NAFTA government documents from 1994, which record tariff rates and yearly repeals for each product. This gets at an important detail about NAFTA, which is while the policy was signed in 1994, the agreement was specifically that products would follow a stepwise repeal schedule. So for products scheduled for a 1994 repeal, this is simple. The average tariff repeal of those products was slightly over 15% in 1993. When the policy hits, the tariff rate is now 0 for those products. For products scheduled for a later repeal date, such as 1998, there was a stepwise tariff repeal each year. And there were also scheduled repeal dates in 2003, 2007, and 2008. Most foods were scheduled for the 2003 repeal, and importantly, sugar was scheduled for 2007. Next is price. So thanks to a high inflation in 1993, the Central Bank of Mexico actually maintains weekly food price data in urban areas. And we collect these data at the product level and match it to the tariffs. So let's first answer some important questions about the relationship between tariffs and prices. Economists say that free trade reduces prices, and we find that that is true here. Namely, that reduced tariffs lead to lower food prices. To confirm this, we use an event study, which compares the prices of foods impacted by the tariff repeals to those not impacted before and after the repeal date. We find that consumer prices were 15 to 30% lower after the tariff repeals compared to products not impacted. So graphed here specifically is the 2007 repeal. That had about a 30% decline. And while this may seem intuitive, it's important to confirm this because food suppliers might capture higher profits instead of passing on lower prices to consumers. And we'll show how we use this in our estimation next. But finally, our last source of data, we link the product level prices and tariffs to the household food purchases and their health outcomes. We use survey data from the Mexican Family Life Survey to observe these changes within households from 2002 to 2009. And this will specifically allow us to examine how households change food purchases, particularly their nutrient intakes from proteins, fats, and carbohydrates. And we can also track their health outcomes over time, so specifically obesity and type 2 diabetes. So we use price shocks due to NAFTA to estimate the effect of food price declines on nutrient consumption within the Mexican Family Life Survey. And there's an important empirical issue to understand in estimating this relationship. The supply and demand for food simultaneously determine the food price. So that is, if we see a lot of demand for sugar, we would expect the price of sugar to go up. And so without a price shock independent of demand, we would have a biased estimate of the magnitude by which prices impact household food purchases. So what NAFTA and tariff repeal policies represent is a shock to the cost of food suppliers, influencing the prices faced by households. Thus, we leverage the NAFTA tariff repeal timings to isolate this exogenous variation in food prices. So using that, we find that a 10% decline in price per calorie results in households purchasing more calories. And across the macronutrients of carbohydrates, of which sugar is a carbohydrate, fat, and protein, we find that price declines enable households to buy more of all types of calories. We find a slightly larger response in total sugar consumed by households in these additional calories. And using the same strategy, we also estimate the effect of food prices on household health outcomes. And these results specifically focus on adults. On the x-axis are the health outcomes, hypertension, waistline circumference, also known as abdominal obesity, diabetes, and obesity as defined as a BMI greater than 30. On the y-axis is the percentage point increase in the health outcome due to a 10% decline in food prices. So we can see that the effect is most pronounced in obesity, where lower food prices, specifically due to NAFTA, account for a 1.5 percentage point increase in obesity. Finally, we examine what percent of obesity prevalence can be attributed to price changes over time. Before NAFTA, there was a baseline level of obesity of 12%, represented by the gray square. And focusing on the light green shading, that represents obesity due to other factors. But if we focus on price, using the observed price changes and estimated relationships, we find that roughly 20% of new obesity cases can be explained by overall price changes. And furthermore, that roughly half of those can be traced to price changes directly from NAFTA. So with that, I will conclude. There is an important tension for household well-being or welfare when food prices decline. Welfare could increase if cheaper food enables households to meet their basic needs. And indeed, we found that food price declines correspond to more calories purchased. But at the same time, welfare could decrease with increasing obesity caused by those same cheaper calories. And we indeed found that declining food prices increased obesity. So with that, thank you very much for your time, and please feel free to send any questions.
Thank you very much, Tara. That was fascinating. We're now going to see two presentations about U.S. healthcare. The next presentation, ethnic and socioeconomic disparities in the time of identification of autism spectrum disorder by Asiya Validova. Asiya is a PhD student in applied demography in the College for Health, Community, and Policy at the University of Texas in San Antonio. Previously, she lectured economics at higher education institutions in Russia, UK, and China. Her current research interests include disparities in children's health, income inequality and health and mortality, public policy and fertility behavior, immigration and labor market. Very diverse. Okay, Asiya, it's all yours.
Thank you very much for introduction. I'm trying to make it full screen. That's strange. Oh, just 1 second. Oh. Just one moment. There is something. Mm.
If you have a problem, I think the PDF was okay.
It was okay when we tried it, but then now for some reason it doesn't show the first slides. Let's try again. So I will try the PowerPoint another one then.
Okay, that sounds good.
Okay. Okay. Is that all right, like that?
I think it's a good solution for now.
I think I cannot do the PowerPoint. I'm sorry about that.
No worries.
Right. So I'm Asa Validova from UTSA, and today I'm going to present my paper on racial, ethnic, and socioeconomic disparities in the time of identification of autism spectrum disorder. The paper is written it aims to contribute the research in the field of health disparities, and looking at this very specific disparity in the time of diagnosis of autism, I wanted first to tell why is this important. So the study of ASD identification disparities increased the public attention due to high prevalence today. So ASD is highly prevalent and one of the most rapidly growing diagnosed disorders these days. So 1 in 54 children, or about 18 children per 1,000 among 8-year-olds in the United States are diagnosed with autism. So the prompt diagnosis and treatment of ASD is a very important factor that can maximize children's functional outcomes, academic achievements, and affect their future life. There are two variables here. One of them is the prevalence of autism among different racial, ethnic, and socioeconomic groups. And another is the timing of the diagnosis. So Autism and Development Disabilities Monitoring Network found that there is lately, as of 2016, there is no difference anymore in the number of Black children identified with the disorder and white children, although Hispanic children were diagnosed at a lower rate than other racial groups. So this is about prevalence, but in this research, I'm moving from disparities in prevalence of the disorder to disparities in the age of diagnosis. So if we look at the time of disorder recognition, we see even higher disparity gap according to the literature. Just a quick look to the prior research. So there is evidence that just like in other areas of child health, the disparities in diagnosis exist, and the timing and accuracy of diagnosis influenced by different demographic and social economic factors such as race, ethnicity, SES, social economic status, and parental education. Prior research shows that Black children are identified as having ASD at older ages than white children. As for Hispanic children, they are less likely to have a documented ASD at all. So the aim of this study is to investigate racial, ethnic, and socioeconomic gradients in timely ASD diagnosis. So it's been documented that social economic status and race and ethnicity, they often have joint effects on health outcomes. And so there could be a confounding between the effect of race and ethnicity and social economic status. So in this paper, I would like to show these disparities, and for the future research, I'm planning to explore the pathways that explain these barriers to timely diagnosis. So on this slide, I just wanted to show what I found in the literature about the and how I structured my research. So there are variables that affect health disparities, which are race, ethnicity, social economic status, including parental education and income. Also, geographical location has an effect. And then these are the pathways that I have not yet explored in this work, but the literature divides these pathways in sort of different domains, which include the family and individual level barriers, like insurance, access to healthcare utilization, family and cultural barriers, which mostly include the parental knowledge and awareness about the autism symptoms in children, and different cultural differences. So cultural differences among racial groups. For example, some race ethnicities, some different cultures basically view the behavior of the children differently. And among some groups, there is a stigma to mental health and trust to providers. So there are also institutional barriers, as quality of care, screening practices, systematic racial discrimination, and segregation. So all these pathways, they sort of stand in between the variables that affect health disparities and our outcome variable, which is the time of ASD diagnosis. Okay, so the research hypothesis. I hypothesized that minority children from lower social classes are at high risk of being diagnosed with delay. So children with disadvantaged backgrounds are less likely to receive their ASD diagnosis prior to kindergarten entry compared to their counterparts from more advantaged backgrounds. So in my research, I look at, let me show you data and method. I use National Survey of Children's Health data, and I include in the sample children aged from 2-year-old until 11 that have been diagnosed with the ESD. So as that have the parents of these children reported the condition and the fact that they received the official diagnosis. So I will test if so I tested in that paper if children received diagnosis before the kindergarten entry, so at the age of from 2 to 5 and from 5 to 11-year-old, so during the elementary school. The outcome variable, therefore, is the probability of getting the diagnosis by school entry. So how early, it shows how early they get the diagnosis. In terms of method, I used 2 different strategies. The first one was multiple logistic regression models. I have 3 models here. The first one includes only race, ethnicity, and control variables as sex, birth weight, and child's age. Second model, in the second model, I add social economic status variables, income level, family poverty level, family structure, and parental education. And the third model includes also sort of captures the role of healthcare. So there are two variables included in the third model. One of them is how difficult is it to get the specialist care, and the second one is availability of general healthcare providers, doctor or nurse. And the second strategy I used is the risk profiles approach using fitted values. So basically, employing this risk profiles approach that account for multiple risks, I created several risk profiles that include at the same time race, ethnicity, income, and parental education. So there are 9 risk profiles, and I compare probabilities of early diagnosis among these groups. So the key results are the following. The mean age of the time of diagnosis in this sample is 4 years, 4.2, 4.3. The simple descriptive comparison shows the high proportion of children of Hispanic origin, in contrast to other racial groups that received ASD diagnosis early. The logistic regression results show that Hispanic children are actually more likely to receive their ASD diagnosis prior to school entry than other racial groups. And the estimates for special care access and availability of healthcare were not statistically significant in the model. As for income, the group with the highest income that was predicted is more likely to obtain the early ASD diagnosis. Comparison of the risk profiles showed that the poverty threshold of below 200% federal poverty level, jointly with low educational attainment, drops the probability of receiving the prompt diagnosis and contributes to increasing health disparity for all of the racial groups. So this is the continuation of the results that I found small difference at the age of the diagnosis between white and black children, but the higher probability of Hispanic children to be diagnosed early, which contradicts the prior literature and the working hypothesis of the minority disadvantage in terms of receiving a timely diagnosis. And I suggest several interpretations for that result.
Asia, you have 2 minutes.
Okay, yes, thank you. I'm finishing. So the first one is the lower prevalence of ASD in children of Hispanic origin, suggesting that they may be underdiagnosed. So instead of being diagnosed at the older ages, they may not be diagnosed at all. Unfortunately, that was the limitation of the survey because we only included those who are diagnosed. And also minority status and language barriers that may explain Hispanic children's lower rate of diagnosis in the population. So the last slide is policy implication of the results. As I already said, joint effect of poverty status and low parental education lead to risks for delayed diagnosis. And the most vulnerable group is the low SES children. And well, here are the policy implications, which state that basically the programs should be designed to help those most disadvantaged groups to get the access to screening and to educate those parents to ensure the health equity. Thank you very much. If you have any questions, I'll be happy to talk more about this research.
Thank you very much, Asia. The next paper is also about U.S. health issues. It's predictable patterns of emergency overdose, poisoning, ingestion events, and implications for public health by Mary Helander. Mary is a graduate research fellow at Maxwell School of Citizenship and Public Affairs at Syracuse University. Previously, she was a senior researcher and software architect at IBM's T.J. Watson Research Center. Currently, she is interested in research that explores topics in public health and its intersection with emergency medical services. equity in healthcare access, aging studies, and also social science research methodology overall. Mary, it's all yours. And can I also remind everybody to enter your questions in the chat box if you have any?
Thank you. Just 1 second here while I get to the presentation. Okay. I assume everybody can see that. I'm like to get into screen share, but I think I'll just go with this for the interest of time. Thank you, everyone. Thank you to the organizers for inviting me to speak in this session. And I'm talking about the predictable patterns from the NEMSIS database, which is a national database of 911 EMS calls that's maintained by the University of Utah. And let's see. So I'll talk about, I'll give a brief introduction and then talk about the methods that were used, the data, and a couple of the models. I will talk about some of the results in the daily patterns that are predictable, and also some of the subgroup differences, primarily between women and men, and also adolescents and adults, and then summarize the findings. In physiology and anatomy and behavioral sciences, there are many circadian rhythms and patterns that are daily across the bottom, and I apologize for these timings being so small, but this is a day in all of our lives, starting with midnight and going to midnight, and you can see various different behaviors and physiologies that have circadian peaks during the day. So for example, our tissue repair generally happens right after midnight. We have the sharpest rise in our blood pressure in the morning, right around 7 o'clock in the morning. We have the highest glucose tolerance in our body during morning hours. Our deepest sleep is right around 2 a.m. And there are physical differences between people, but these are generally the peaks. It means that these things are more likely to occur at those hours of the day. It turns out with emergency medical system dispatches, when 911 is called and an ambulance or an agency, a medical agency is dispatched to a medical emergency, that these dispatch events actually follow circadian patterns as well. So this is data from the National EMS Information Systems. These graphs are from 9 years from 2010 through 2018, and you can see in different dispatch types there is a very strong circadian pattern where in certain times of the day you have a peak, not as many events occur, and then in another point in the day you have a valley, and then in another time of the day you have a peak. So in this talk, I'm going to focus on overdose poisoning ingestions. That's a category that includes everything from alcohol and opioid poisonings to acetaminophen, detergent poisonings, anything. And that pattern effectively follows for all subgroups this type of sinusoidal wave where there's a valley around 6 a.m. in the morning and a peak around 9 p.m. in the afternoon. In the evening. Before I go on to that, just want to mention some other patterns. You can see, for example, for traffic incidents, there's a sinusoidal pattern with a bump around the commuting times. For choking, there's a sinusoidal pattern, but there's little extra bumps around the meal times. And then, for example, drowning, most people have their drowning accidents, unfortunately, right before dinner time or right around the dinner hour. It's a much more smooth wave. So there are differences in the patterns. I will focus on the what we call OPIs, or overdose poisoning and ingestions. The data is a very rich data set. The data set that I use is actually 10 years. I included the 2019. 2020 is just coming out. It will add another 40,000 or so dispatch events. This 10 years of data, these dispatch events are just over 200 million different events. Each event corresponds to a patient care report that's de-identified completely. Within those, there are just over 3 million overdose, poisoning, ingestion events. So that's the data size. It can be described as a very, very large, comprehensive, convenient sample. So it is not a random sample. It is not a complete population, but in later years, we're getting closer and closer with the newest versions to a complete population sample. Although there is some suppression by states and some loss of information, it's a fairly comprehensive and good data set. Of the 3 million plus overdose, poisoning, ingestion events, what we do is we take the events and we bin them into hours. So in the 10 years, there are just over 92,000 hourly bins in the 24-hour period, and then collapsing to 24 hours, then we can see the distribution over the course of a day, and then we can see the sinusoidal curve in the day. So talk a bit about models and what we did with this data. The first thing that I tried was just doing a sinusoidal regression model, and I included on the left just the mathematics. It's really just some simple trigonometry that takes a model that is a classic sinusoidal wave, that's this top form, and transforms it with some trigonometry and some substitution to a linear regression model. And I believe that has been, when I presented this material in the past, it's been one of the most frequent questions. How do you actually use a linear regression model to model data that's obviously nonlinear? And that's how it's a very nice, elegant trick. Once we have estimated the parameters for this linear regression model, we can always go back to the sinusoidal model and get the classic parameters for sinusoidal frequency, amplitude, horizontal or vertical shift. So that was one type of modeling, just to look at how to model the predictability of this pattern over the day. And then we also looked at subgroups by sex, by gender. We did some other work on race, ethnicity, and others, but today I'm going to talk about the gender differences and also the subgroup differences by age category for adolescents. And for those methods, we use G-test and contingency tables to do the comparisons of these distributions and compare them by relative risk. So for the sinusoidal pattern, basically got very nice smooth curves. This is just an example of one of the regression models. It really depends on which subgroup we're looking at and if we include that in the model. This was the most straightforward model, and the purpose of this chart is really to show, using the estimate of the from the regression model, the sinusoidal regression model, we can then derive prediction limits, 95% prediction limits, which are the green bars. The prediction limits then have a really nice feature, and that is they allow for anomaly detection. So this is actual data from 2 weeks in 2019. There's an anomaly. It was a spike at one particular hour in October, about a year and a half, almost a year and a half ago now. The prediction limits allow us to notice when those automatically when those anomalies occur. What's interesting also is we can notice anomalies in the other direction when there are fewer than expected overdoses in a pattern. So that's the predictable patterns. I'm going to talk briefly about the differences between women and men, and also adolescents and adults. When we did these comparisons of groups, first of all, what I want to say is everything was significant, although the significant levels were although they were significant, the actual differences were very small. And I should note that there is statistical significance, but very, very small practical differences. Contingency tables were used to statistically look at each hour to find the significant differences in hours. This is a graph that shows the comparison of males and females by hour. Graphically, they look very, very similar. When we start to look at the 95% confidence interval for the relative risk is when we see the differences, and it shows that women have a bit higher risk than men during the day, during the hours that correspond coincidentally to school hours, which we thought was interesting, and men having a little bit higher risk right after work and in the middle of the early morning hours. In terms of adolescent risk, this is the hour by hour for all age groups. There are obvious differences between all of the age groups, but the differences that we found quite stunning were the adolescents to the adults. Graphically, these start to look very somewhat similar, but when you compare them hour to hour, it turns out that the adolescents have a bit higher risk during during morning hours right after school starts, which we thought was an interesting result. Right after, as my dentist said, the emancipation from parents in the first thing in the morning. So that was an interesting result. In summary, the overdose patterns from 911, they're very predictable. They follow a daily sinusoidal pattern. For overdose poisoning ingestions, these peaks tend to occur between 9 and 10 o'clock at night. There are pattern differences based on sex and age groups. Women have higher risks during the daytime, and adolescents right after school starts. More research is needed, especially in behavioral sciences and physiology, to help understand these mechanisms that underlie the circadian patterns. We think that could be really interesting and useful for coming up with prevention interventions, especially for adolescents. I didn't mention this, but there's also a slight different pattern for older adults that shows they're more at risk during the day, probably coinciding with prescription overdose errors as opposed to recreational drug use. That's a hypothesis. But it's something that is worth looking into as well. Some of the limitations of the study, I mentioned that NEMSIS is a convenient sample. It's very large and comprehensive, but it's not a random sample. It's not a full population. Although the size of the data actually does approach the population size, especially in the later years and the later versions of the information system. These patterns are also based on the best impression at dispatch. Sometimes there are errors by emergency medical dispatch call takers. This is not quite a diagnose, it's an impression, but it's the best impression that's made upon the 911 call that happens. It may be changed on the scene when a paramedic or an EMT arrives and observes the scene or observes the patient. And also these impressions may be changed again when the patient is delivered to the emergency room. They could have a breathing problem or a diabetic emergency, or be having another medical emergency and not an overdose. So those are limitations. One of the things we're doing in the next steps is actually looking at the data more closely in terms of the ICD and the SNOMED codes, and filtering out the specific overdose diagnoses, so that, for example, we take out the acetaminophen overdoses and separate accidental overdoses from overdoses of alcohol or other drugs of recreational use.
You
we'll
have
also look at
2 minutes.
Oh, thank you. Thank you, IJ. We'll also look at some of the, as I mentioned, some of the prevention implications by subgroups, And finally, with the same data, I've been looking at some other forms of anomaly detection using machine learning. This is a recurrent neural network result that was quite promising. This graph shows the same daily pattern and the resulting prediction from a recurrent neural network. So that's what I have, and I'll end there and say thank you, and look forward to questions.
Great.
Thank you.
Mary, that's fascinating. I think we're going to have a lot of good discussion. Our final presentation is the application of agile demography to optimizing the utilization of science for health systems strengthening in Africa. Big topic by James Phillips. Jim is Professor Emeritus at Mailman School of Public Health, Columbia University. Prior to his retirement in 2019, I didn't know he retired. He directed research on health systems development in Asia and Africa. Ever since 1992, he has been engaged in experimental on health systems development in Ghana that developed, tested, and scaled up approaches to the delivery of community-based primary health care. Jim, it's all yours.
Thank you. This presentation is going to be a bit different from others that have been shared with us in this conference. Instead of presenting results and demographic analyses, I'd like to discuss a process. The process has been developed over a period of years, and a concept that underlies the utilization of research. This is a conference on applied demography. And if we want to be successful as applied demographers, we should be concerned about the question of how to translate what we're doing into policy itself and actually implement the results of our research. I have worked in countries where the mission of our team was not to generate demographic research so much as it was to generate change in a national program. And that is a fundamental challenge that is captured by the slide that I'm showing now, is how do you actually design a research so that you optimize its utilization for policy? Well, implementation research, of course, is not a new idea. As we can see from Greek philosophy, implementation research is as old as science itself. But, you know, with the Second World War, implementation research became a critical factor and in translating science into action. And we have taken advantage of the research and action that has followed the Second World War to develop a paradigm for health system development. The work that I'm describing was developed first in Bangladesh in cooperation with the World Bank and its consortium of donors. My work is primarily funded by the Government of Canada. We then used the lessons from this experience to share and indeed develop a working group of WHO. It became an international NGO known as ExpandNet. You can still see a display of what ExpandNet does. It worked in about 18 countries. Part of the ExpandNet agenda was to transfer the MATLAB scale-up paradigm from Bangladesh to Ghana and from Ghana to other countries. And I would like to just take our time today to discuss the Ghana paradigm, since our time is short. I'm going to just talk about the concept that underlies all of these stories is phased development of a program. And what we're trying to do is develop agile science methods that have been instantiated in the field of artificial intelligence by computer engineers. Computer engineers sometimes are confronted with the task of developing software that meets specifications of their user or their of the environment where they're working. And they don't develop a final product, they develop a process of continuous software engineering. So we're trying to derive inspiration from agile computing and see if this works in the context of Africa. In the Ghana case, this started with a micro pilot in 3 villages designed to develop participatory understanding of what was wrong with healthcare and what strategies might work. That was followed by a factorial trial, actually a quasi-experimental study that generated results. There were a lot of questions about the utilization of that results, problems and barriers to putting that experiment into action as a national scale operation. So that caused a phase 3 process to be undertaken that involved replication research for developing milestones and clarification of the scale up process. And scaling up itself had research associated with it as phase 4. We argue that these phases actually have transformed primary healthcare in Ghana. We're quite proud of what has been achieved. We've gone from 3 villages to 6,200 villages. Childhood mortality has been reduced. Fertility has been affected. Ghana's positioned now to be one of the first countries in Africa, perhaps the first, to achieve universal health coverage, in part due to the community-based primary health care contribution that this research system represents. But we're not going to argue that this is the end of the story. It's a process, and we want to improve upon it, and we want to recognize that there's much more to be done to develop our paradigm further. We have identified 12 major pitfalls or problems with what we call embedded science. That is, we function with terms of reference to the government of Ghana as scientists that report to the implementers. But we have donor timelines, ways of working, concepts of research that are disconnected from the environment that we want to influence. And that disconnectedness is most critical with respect to timing, because research results do not correspond to the pace at which decisions are made and plans are developed for national implementation. Incongruence is another problem, because the way in which research is managed to create knowledge is very different from the way implementers manage knowledge to make decisions. And complexity of research is inconsistent with the decision-making environment. Well, I refer to all this in a way as the New Yorker's orange cone problem. You know, anyone who's visited our city knows that it's full of potholes. You know, everywhere you go in a taxi or try to drive around, there are potholes, and these potholes are graced with orange cones, which represent a signal that somebody has recognized a problem and has figured out that something needs to be done. And they put an orange cone there rather than actually doing anything. And these orange cones can remain in place for years without any action. Researchers to an implementer are very often part of the orange cone phenomenon. We identify problems rather than solutions. We are not participants in the problem-solving process. So that problem of timing is an outcome of this incongruence of research with management decision making. What we've done, and we think, is we've developed an approach of formulating research in partnership with our implementers, so that the phases and actions that are taken are represented by this paradigm in this diagram. I'm going to come back to this, but I just want to point out that what we're talking about is not at all a project. It is a process that never ends. It is not a project. And that getting out of the orange cone phenomenon means you work on a management process paradigm rather than a project outcome paradigm. The core purpose of this activity is to curate knowledge rather than to just develop knowledge. Knowledge curation means you're changing the mindset of all the stakeholders in an organization so that institutions are learning, not individuals. This is the problem. You have in a health system in a closed management operation where knowledge tends to be inside the bureaucracy, channeled upward based on clinical records or management criteria that are somewhat separate from the communities that open systems research implies. And policies, in turn, develop a top-down character without adequate knowledge about the population being served. Researchers, in turn, tend to focus only on the demographic environment to the exclusion of knowledge of the system that they aim to influence. So there are experimental studies, or there are demographic studies, or there are qualitative research studies that identify important problems that get channeled upward, but the system is ignored in the process of generating and sharing this information. So what we recommend and what we've done is we developed a system of knowledge generation and management that mirrors the system of management itself. And it's captured by this diagram, showing that we create learning localities, learning districts, and learning regions of the country where the systematic research capabilities integrated into the system, and that integration is conducted in the context of knowledge sharing. So peers are organized in ways that they can share what they learn with counterparts from other regions, districts, or communities. That generates a learning system that then embeds organizational learning into the policy communication process. We have an important contribution of demographic research in this paradigm. It's a rather complicated diagram, but I want to just simply say that we collect DHS-like demographic data in cycles with clustering that represents catchment areas of primary service units. And then we capture data up and down the line that permits systems modeling of functionality and readiness to provide care as determinants of household behavior. We also conduct qualitative research, so we have a mixed method paradigm, and that qualitative research is also hierarchical, recognizing that if you want to change a system, you better represent the way the system functions and the way you collect the information that you want to purvey.
Jim,
Well,
you
this-
have 2 minutes.
Okay, this leads to a rather complicated problem of modeling. And you can't possibly translate this model into something that people are going to understand and use if you go about it directly. What you can do instead is use the model to simulate the production of routine reports. That's something a model can do. You can generate a Ghana Health Service a report using a rather complicated model. So we have a series we call Making the System Work, which reads like an ordinary manual, but has in the background the model that you've seen. Okay, so to develop our knowledge management system, we first took the closed system and we developed feedback within it. And we have entertaining to read narrative reports that correspond to the learning localities that represent our system learning program. And we have then exchanges that make use of this printed information for team exchanges. And this agile system of learning and sharing of information creates knowledge curation rather than just the generation of knowledge. Knowledge curation is continuous, it's production process focused, and it's not just limited to research. It's any experience that can be communicated in a way that research is conducted so that shared data capture, data utilization, data learning extends across these 4 phases and permits phases to be revisited for system reform. In the case of Ghana, they're using this now for reforming the original program and redeveloping its functionality. This is our rendition of Agile demography. Believe it or not, it has an overarching optimization theory and paradigm that we are in the process of developing to quantify all this and enable us to understand if we're really making a difference in the way things work. Thank you.
Well, thank you. I want you to talk to all of our donors these days. I want to thank all the presenters and congratulations to you all for sharing your interesting work, but also making your presentation really concise. Everybody was on time. I think this is time for some Q&A discussion. There are a few people, including myself, putting some questions in the chat box, but you should all feel free to ask questions. May I start with my own question to Tara, our first presenter? Basically, what are your thoughts about the mediating interventions of this price shock? You don't want to raise the price back up, right? Also, any comment about the already increasing trend even before the price shock?
Yeah, fantastic. Thank you very much for these questions. There are a lot of policy proposals on the table. So taxes, labeling, food subsidies, informational interventions around healthy eating, in-kind food transfers of fruits and vegetables, and banning ingredients that are particularly harmful. And one of the takeaways from this work is that sugar prices fell 30% from NAFTA. And that decline is only due to NAFTA. Prices could decline due to other causes, such as different production technologies, introduction of high fructose corn syrup, et cetera. So when you think about a 10% soda tax, that's actually a relatively small disincentive in light of all of this. The other interesting thing is that taxes are also a very blunt policy instrument. Ideally, policymakers want to tax the 3,000th calorie, right? The stuff that's actually unhealthy, not the first calorie. And there are actually some studies in the United States that show taxes on meat actually correspond to increased child anemia. So I guess I'll sort of, it's an active area of research. It's almost certainly going to involve a bunch of policy instruments. I think I probably have two points on it. One is that various OECD reports have found a lot of promise in labeling policies to help inform consumers if a product is particularly high sodium or high sugar. And then I didn't touch too much on this in the presentation, but it's also important to remember that these price declines mean that households can spend less of their budget on food. So for a household spending 50 or 60% of the budget on food, that money might be reallocated to education or heating or some other basic need. So there actually might be some health benefits to that. And then to the question about the secular upward trend. So there is a secular upward trend everywhere, including Mexico, but also globally. And this secular trend could be due to a number of sources. Aging is the obvious one. So we control for secular trends by including year dummies and age. And so this price shock, the way to think about the price shock is as a slope shift, accelerating the rate of obesity. And in terms of just descriptive statistics, this is sort of particularly true after 2007, which was the sugar tariff repeal, where there's a sharp increase in the rate of obesity in this globe.
Okay, thank you, Tara. We got some more questions to Tara. How are we doing in terms of time? Maybe let's just make sure that every presenter can get one question, and then we'll come back to a group of questions for each presenter. I think Asia had a question from me, but did anybody have a question for Asia? I think, yes, there was a question for Mary, from Mary to Asia. I wonder if there are rural-urban differences in the ASD recognitions. Have you considered that? Any intuition on which low SES children might be less recognized?
Yes, there is one paper that is devoted to rural-urban differences, actually, in ASD diagnosis. I have not included that variable into my paper because it is not available in the survey data, But in general, of course, there is less due to lower access to specialist care and to the screening. Families who live in rural areas are more vulnerable in this regard, and so they get the diagnosis later in life, which has a lot of negative consequences, of course, for children with this disorder. And the other question, I can answer that as well from about the sample size. So the sample itself, the survey sample itself, includes children from 0 to 17-year-olds, so a big age range. But I included, for the purpose of this research, only children from 2, because if they're younger than 2, it is very difficult to identify the symptoms, or even acknowledge or recognize the symptoms, even by parents. So specialists, the healthcare providers these days can diagnose at the age of 2, sometimes earlier, but it depends. So I included only starting from 2-year-old and until 11, until the end of elementary school, because yes, it is a binary variable showing if the diagnosis was made before school entry or after school, and or in elementary school. So included elementary school children and children who didn't start the formal education yet.
Thank you. Okay, I think we have only one question for Mary, which is from me, and I'm going to flip the order. So if I'm the paramedic, what would you tell me? What does this study mean for me? Because I care a lot of emergencies, not just the OPI. And the other one, I thought it was fascinating that you showed a different, slightly, but still significantly different pattern between adolescent and other age groups. And even those young kids, it's completely different pattern. Do you have any thoughts on those age-specific, mostly preventive measures that you can think about?
Sure. Thank you. Those are great questions. As a matter of fact, I did preview the results with some of my paramedic friends, so I have a little bit of insight into what they said back to me. I'm a certified and nationally certified emergency medical technician, so that helps me a little bit. But since you asked about paramedics, one of the things that came back to me when I showed them the results on the OPI patterns was, wow, this really means that we have to be a lot more careful, and it emphasizes the data collection because they're really responsible for collecting the data along the events and into the patient care reports. That was their first reaction back to me. How they found the data itself and the patterns useful, I think anytime you have more understanding of when and what to expect during the day, during a shift, some paramedics are actually out sitting in a rig, parked someplace, ready to go. They don't go back to an agency. Others, particularly at municipal fire departments and ambulance bays, they're sitting there waiting for a call to happen. And if you know, for example, that your opioid overdoses are more likely to occur during the early evening hours, you can make sure that you have certain drugs on board, like Narcan and other types of drugs for other types of overdoses. If you know, for example, that a stroke is more likely to occur at a certain time of day, you can have certain people on your staff assigned to those shifts. For certain kinds of overdoses, for recreational drug use, it could even be interesting to have social workers be on the rigs or be available for rigs in the evenings when recreational drug overdoses occur. So there's a few things, YJ, and that's an excellent question. I'll probably try to get some more information about from my paramedic friends to maybe dig into that a little bit more. In terms of age group differences, that's a really interesting question. And I think, and this is not my expertise, but my co-authors have a bit more expertise on the behavioral side than I do. For adolescents in particular, we don't really know what they're doing. We can kind of guess because we were all adolescents at some point, and leaving and going to school, to high school, 7, 8, 9 o'clock in the morning. What are you doing? Why are we seeing overdose patterns at that time? And so I guess I hesitate to say what to do to prevent those, other than we need to do more to maybe listen to the kids and find out what they're doing then to be able to help them. That would be my first thought. Secondly, for the older adult population, I didn't show those results, but for older people, pharmaceuticals are so complicated and they often have lots of them. And these could be mistakes. There's lots of people who live alone, older people who live alone. What can we do? What kinds of things can we do other than just the pill rack? Here's what you take at 8, here's what you take at 9, here's the 3 pills that you take at noon with lunch. Like, what other things can we do to help them with their drug taking? There are some drugs, such as warfarin is a huge problem. It's a blood thinner that many older people are on. It helps people who have AFib prevent throwing clots. That's the number one cause of strokes. but that's also a drug that creates a lot of overdoses. And so if we know that, and we know people are on warfarin, we can do more training to actually try to help them prevent those overdoses. So yeah, thank you. Thanks for those questions.
Sure, thank you,
Hope that
Mary.
answered.
Yes. Okay, I'm going to ask a question to Jim from Mary, but at the same time, I want to ask all of you just to scroll down the chat box and see if there are any questions that you want to respond to. So Jim, we have a question from Mary.
Yeah.
She said, I am interested in how policy design can be sensitive to local culture. Can you comment on how the model might consider?
Thank you. I don't know if you can hear me. You can. Okay, good. This is a very good question and critical to policy development in Africa. There are 14,500 ethno-linguistic groups in sub-Saharan Africa. If you look at Bangladesh, huge country that it is, it has one ethno-linguistic group, maybe two religions, but, you know, so Mary's question doesn't arise in a place like Bangladesh where you develop something, you fuel bureaucratic decision-making, and you get donors lined up, and they march out resources to make things work at scale. And it just cascaded into a massive program in only 5 years. Ghana is 27 million people and 82 ethno-linguistic groups. These groups are fundamentally different from one another. The Akan are matrilineal. The rest of the country is patrilineal, and on and on and on. The differences are profound. So what we argue is to scale up, you have to scale down in a situation like that. What matters is the process and the paradigm where you have learning localities, a learning process, and you use the learning to adapt and develop the strategy for that locality at scale. So a district has its own development program and flexible resources to carry it out. But you don't argue that what's done in one district must be replicated in another. Even the replication experiment was in 10 districts initially, and that we got scaled up into 20 replication districts. So the whole idea is process. We believe the process of learning in a locality by systematic way, emphasizing qualitative research, then quantitative research and replicating and scale up, and so on. The paradigm of phasing things in a local way can be done at scale. That's kind of hard for donors, I think, to embrace. So a lot of the conflict here has been with the donor community. Donors tend to even take particular districts of the country as their district. They have a kind of a mistrust of the African way of organizing and getting things to work. So there's this institutional mistrust of the external players who have critical resources. You find less of this mistrust in Asia than is prevailing routinely, I think, in Africa. So it's a complicated problem that Mary is alluding to. We think we have a solution, but I don't think we've sold it very well to many of the key players.
It's a difficult sell.
Yeah.
Thank you, everybody, for your presentation and answers. Does anybody want to respond to the questions in the chat box?
I can speak quickly about imports versus local foods. There are actually three really interesting parts about this. The first is that imports and competition will sort of reduce all food prices, including local food prices. There was a really interesting study of Walmart entry in Mexico that sort of, it wasn't specific to food, but it basically showed that for the same barcode items, Walmart was offering 12% lower prices. So sort of local producers have to respond to that because otherwise it's the same thing just for cheaper prices. The second part is it's also now possible for local producers to import cheaper ingredients. So the final product might be like locally produced, but it's possible to sort of get the some components of it sort of for cheaper. And then but it is and then the last part of it is you know, there's sort of from a very with health science, there's something called the nutritional transition, and that basically alludes to there's a Western diet that sort of is high sodium and high sugar, and that with globalization and industrialization, there's sort of this supply expansion of just like new foods that are available, right? Like Cheetos are now available. And that is a really important component of this. If anything, it's actually, so this study focused at prices, right? Just prices. And sort of looks at those first two factors. But the idea of import exposure and new products is in that green area of like other factors that contribute to obesity. Yeah, it's actually a really interesting area of future study.
Thank you, Tara. I think we covered all the questions, right? And I have my final duty to let you know that tomorrow is the last day. The session starts at noon Eastern time. And do not forget to register for the PAA annual meeting in May 3rd through 5th. It will be a virtual meeting. And thank you for attending. Congratulations to you all.
Thank you very much.
Thank you.
Thank you.
Bye.
Bye. It was a pleasure. Bye.